Everybody, and thanks for coming. Thanks for inviting me. I've got the job of trying to put into 10 minutes what my job is all about and what we do. Can I just check, Nick? Can you see? I can see your head in the square. Can you see the talk?
Yes, we can. Yeah, thanks.
Fantastic. So I'm Vanessa Loftus. I'm the consultant in the memory service at Tolworth Hospital. And Nick's already talked a little bit about the data, about the numbers. And what's the point of the title of my talk? And actually, I think the biggest issue is that dementia is a big problem. And it's not a normal part of aging, but it's certainly not a rare condition. So I think because it affects and touches so many of us, it's really important for us to know a little bit more about it and what we do about it and what we do for you in the clinic. So I just thought I'd take you through a little run through of what happens. So by and large, we get referrals from the GP. We may get them from Kingston Hospital, but somebody will refer you in to us, and invariably the GPs now are brilliant when it comes to arranging the delirium screen, so arranging a blood and urine set of tests to ensure or identify if there are any other issues going on that could be even reversible causes of cognitive impairment that the GPs can then address. So once that's done, when we get somebody referred to us, one of our lovely nurses will make a phone call to you at home to clarify that you're still interested in coming to see us, but also that you can bring a family member or friend, and we offer you an appointment at home or ideally in the clinic, but if it's more suitable, then we will come and see you at home. That's normally, that first assessment is normally done by either me or one of our two nurses, 3 nurses when we're full complement. And it's usually for an hour and a half. I'll stop fiddling with the screen in a minute. Usually for an hour and a half, and that involves a question and answer session. We ask about your medical history, medication, all about the memory changes, and also we will do a memory test that can either be a brief one out of 30 points or a longer one out of 100 points, which can take between 5 and 20 minutes, depending on what we think is the best suiting for you at the time. Invariably, due to various government targets now, and we've got much slicker at things, and with our skill set has gone through the roof over the last few years, that we aim to give you a diagnosis on the day, or certainly a provisional diagnosis. We invite most people, but not everybody, for a CT or an MRI of the brain scan as part of the assessment, and we then load you up with some fact sheets and information as much as we can to give you that chance to reflect and to read a little bit after the appointment, because often, we know that when we sit in an assessment for an hour or an hour and a half, we're not going to remember everything that's been discussed or even that what's been told you at the end. So we'll give you lots of paperwork. Medication may be started on the day, which I can talk about in a little bit later. But then there's also lots of signposting. So this is our ideal opportunity to refer you with your consent to various other agencies, such as the Alzheimer's Society. I've done lots of abbreviations, apologies. Cognitive stimulation therapy, which I can talk a little bit about later on if you'd like me to. Kingston Carers Network, which is an amazing agency that supports the carers, who are as important as the patients that we're seeing, because a well carer and a well supported carer means they will remain a better one for longer. We may need to, as Steve said, refer patients to social services, and some of you may need or benefit from an occupational therapy assessment. Now, if any of you have come to my clinic before, these are the 3 blue circles that we use to try and describe. This is the tool we use a lot to try and make it easy for our patients to understand what we're going on about, basically. So we divide patients into 3 groups usually. Somebody who's come with a normal memory, which we may well see, and no diagnosis comes out of the appointment, but I'll talk about that in a minute, where somebody's memory score is good and their ADLs or their activities of daily living, their functioning is intact. We then move down to somebody with more significant memory changes, but where their ADLs or their functioning is still intact, and where they may get a diagnosis of mild cognitive impairment. And then further along the memory lane, if somebody's memory is more significantly affected and enough for that to affect how they function, they may get a diagnosis of dementia. And AD/VD is Alzheimer's disease and vascular dementia. They're the 2 most common types of dementia. So just that I've touched on most of this, but you may come and get no diagnosis. So we do see a number of people that come that maybe have a family member with the diagnosis of dementia, and they come with the anxiety that they may have dementia. And then once we've been through the process with them and the assessment, no diagnosis is achieved, which sometimes can be extremely therapeutic. We may detect that you have a mental health diagnosis rather than a cognitive one, such as depression and anxiety, which can really affect our memory and our functioning. And at that point, we tend to ask the GP, we refer people back to the GP and ask the GP to refer for either therapy, medication, or both, to try and get people back to full mental health so that we can see them again in the future when they're firing on all cylinders. So patients may get a diagnosis of mild cognitive impairment, or, as I said earlier, a dementia diagnosis, which could be, there are 40 different kinds of dementia, but these are just a few of the more common ones that we're more likely to see in the memory clinic. Okay, so MCI, mild cognitive impairment, is that middle circle that I said that we will give somebody a diagnosis of if their scoring memory is impaired, but they're still maintaining their functioning, so they don't need reminding to do things. And about a third of people with mild cognitive impairment may progress to a dementia, but 2/3 don't. And that's really important to remember, that it's not a given that somebody with mild cognitive impairment doesn't automatically progress to dementia, but they're much more likely to. That's why we then hold on to people and see them again if they get an MCI diagnosis. So because I love this wheel, I discovered it on recently. So because there are chances in between the mild cognitive impairment stage and dementia, we can do some things to actually try and slow down that progression from MCI to dementia, and that's all about dementia prevention. So what we need to really look at, particularly I think the most important are the left-hand side of the circle, but all of them are totally relevant. So nutrition, essential. So eating healthy, ideally it's a Mediterranean-based diet with fish. For some reason I put veg and root, but actually obviously I mean fruit, nuts, olive oil. So things that are low in fats and high in good fats, low in bad fats, but that whole 5 a day, but lots of healthy fruit and veg is really important, and trying to aim for the low fat approach. Exercise, so we talk about that a lot in the clinic, but it's important to not suddenly advise our patients to start doing a marathon or a 100-mile cycle if that's not what they enjoy or it's not safe to do, but to do things they're normally doing or feel comfortable doing that gets them moving. That's the most important thing, which is kind of proportionate to what they normally do. Trying to avoid big stress is really hard, but certainly making sure people have the social support and family support to manage those stresses, because stress is very toxic to the brain and can be damaging to the memory. As is sleep. Loss of sleep, we all know what that's like after certainly and even one night, but some patients have quite chronic poor sleep that I see in the clinic. So we do try and look at all the sleep hygiene approaches that could maximise that, to maximise somebody's cognitive function, and trying to avoid the risky behaviours that smoking and alcohol can make our blood flow slower, make our blood more sticky, and that can obviously impact quite impressively on our cognitive function as well. And those, particularly the alcohol, is a really good example of a reversible cause of cognitive impairment. We see people in the clinic that are drinking excessively, and then we give them the appropriate advice, and 6 months, 12 months later, their their cognitive function could improve quite significantly once that's managed. So just coming to a few additional things. So puzzles, mental stimulation is really important. Puzzles, doing things that you enjoy, not to start deploying complex games of Sudoku if you're not used to it. Doing things that you love doing things with other people. Reading, but maybe talking about what you've read, even just reading the newspaper and discussing things after reading a page or two with your partner or with your family member. Vitamin replacements, there's good evidence to say vitamin BD and folic acid can improve cognitive function. The GPs are fabulous at identifying and treating hypertension, cholesterol and diabetes, and again, people with out of control diabetes, it can hugely affect on their cognitive function. So identifying that, treating it and managing it can make a real big difference. And the same with depression, anxiety and other mental health conditions. So dementia. So that's the circle to the end of my memory lanes, which I'm going to talk to you a little bit about what we can do about that. And I've broken it up into two, mindful of time, two areas briefly, the psychological interventions and then the medical ones. The psychological interventions, for me, one of the most important things we can be is name it. Things we can do is name it. Identifying the diagnosis and talking about it, explaining what it is, decoding it in a way. And also that in itself, there are so many people every week that many of the patients I see have an idea, or their relatives have known something's coming along, something's been happening, and they sometimes find it quite a relief, not always, to actually have a name for it and have a plan for what to do about it. And after a year or 2 years of worry or confusion, it can be really quite a therapeutic process. We then link, when somebody has a diagnosis, we have somebody from the Alzheimer's Society, Layla, who sits in our clinic with us and who works closely with me. And once we diagnose a dementia, then automatically we offer the patients and their families some time with Layla and the Alzheimer's Society in our Kingston clinic. We have signpost people to Kingston Carers Networks and all the other groups that are available, carers support groups, social activities and things like that can be really a good sense of support, and for carers support as well. We and Layla and various other members of our team will talk to the patients and families about the financial aspects. They can qualify for council tax reduction or even exclusion, and lasting power of attorney is another kind of legal element to this diagnosis, which is relevant, as is driving, which is not on that slide. We do always talk, when we talk about a diagnosis of dementia in the clinic, about driving, the implications, the safety of it. It doesn't automatically mean somebody has to stop driving, but just like epilepsy, it's notifiable to the DVLA, and we always encourage and strongly advise someone with a new diagnosis that they have a duty of care to inform the DVLA of their diagnosis. And then finally, last but not least, medication is available, has been for some time. These are the 4 tablets that are available nowadays, and the most common of which we advise or request the GP starts is donepezil. It's not a wonder drug. It doesn't cure Alzheimer's or dementia, but it can, in about 1/3 of patients, help to slow it down. Okay, and then how does the future look? So things are starting to look a little bit brighter. There are new medications coming along, new research happening. The new medication that you may have heard in the press, lecanemab and donanemab, the new medications are largely at the moment in infusions and drips. So we've not had them approved by NICE as yet. So that's not for now, but hopefully continued research in the future will bring us more medication. So thank you very much.